Welcome to the 8th session of IACTA, Virtual IACTA 2021. This session is on hemodynamic monitoring and will be moderated by Dr. Yatin Mehta, sir, our beloved Dr. Yatin Mehta from Medanta Heart Institute, Gurgaon. Over to sir.
Thank you, Sandeep. It's indeed a pleasure, and I must congratulate the IACTA organizing committee for organizing such a good meeting. So I welcome the four chairpersons for today's session. First, Dr. Manju Bhutani. We all know her. She's one of the founding members of IACTA and past president. We also have Rajesh Mishra, who has been with me for a long time and now at Max, and he has been the treasurer of IACTA. And we have Professor Khalilur Rahman from Bangladesh. He's one of the leading lights of cardiac anesthesia in Bangladesh and a dear friend of mine. And last but not the least, my dear friend, Dr. Naveen Malhotra from Rohtak. He's professor of anesthesia and pain management at Rohtak, and he's also secretary of ISA and RSSCB. So over to Manju for introducing the chairperson, the speaker.
Good morning, everyone. We'll be now starting a very important session. We've got Dr. Vijesh Venugopalan talking to us. He is the professor and head of department at KMCT Medical College, Calicut, Kerala. Everybody knows him. He has a lot of experience in cardiac anesthesia, a lot of papers, publications, lectures, and special interests. So let's welcome him to his talk, and we'll be looking forward to it. Thank you.
And good morning. It is my proud privilege to introduce Dr. Swami Das and Dr. Avik Jayant. Dr. Swami Das is an associate professor in the Department of Cardiac Anesthesia, IPGM ENR, Kolkata. And she'll be talking about PA catheter, a fading tool amidst an advanced armamentarium. Dr. Avik Jayant will be he's a clinical professor at Amrita Institute of Medical Sciences, and he'll be talking about venous function, practical implications for cardiac anesthesiologists. Thank you.
I would request the first speaker, Dr. Vijesh Venugopal, to start his presentation on goal-directed hemodynamic therapy.
Good morning. At the outset, let me thank the organizers for making me part of IACTA 2021 and giving me the opportunity to present a topic on goal-directed hemodynamic therapy. I have no conflicts of interest to disclose. Coming to the topic, hemodynamics is concerned with the forces generated by the heart and the resulting motion of blood through the cardiovascular system. Hemodynamic monitoring is the intermittent or continuous observation of physiological parameters pertaining to the circulatory system with a view to early detection of need for therapeutic interventions. One can ascribe the birth of hemodynamic monitoring to the British anesthesiologist Dr. Joseph T. Clover, who emphasized the need of one's finger on the pulse of the patient while anesthesia is being administered. The ability to optimize hemodynamics to ensure adequate organ perfusion and to improve clinical outcomes is one of the many holy grails in anesthesia and intensive care. Which hemodynamic targets we should aim at to optimize patient outcomes remains elusive and controversial. How to use and interpret these targets is the core issue based on a physiologic point. One size does not fit all because we have patients who have different biometrics, who have different subsets of comorbidities. So one size or one algorithm will not fit all patients. The high-risk cardiac surgical population have poor cardiopulmonary reserve. So if the impaired oxygenation balance is not corrected early enough, mitochondrial damage takes place and the insult becomes permanent. We know from our days in physiology that for optimal survival and function of the cells, two physiological objectives are to be met. One is the adequate perfusion pressure in order to force blood into the capillaries of all organs, and the other is for adequate cardiac output to deliver oxygen and substrate to the cells. So when you are faced with a situation of hemodynamic instability, the therapeutic options in your armamentarium are limited to just three. You can either give a vasopressor, you can give an inotrope, or you can give fluids. Now, depending on the hemodynamic monitoring and depending on the group into which your patient falls, you can decide on which therapeutic option to use. For example, you have, or the first scenario, if the patient is vasodilated, this you can see from the diastolic blood pressure in an intra-arterial trace, or objectively you can see that your SVR is low. And this can be detected by if you have a pulmonary artery catheter or a flow track device. And in such scenarios, you will give a vasopressor. Coming to the second scenario where the patient requires volume expansion. So you will have to decide when to give fluid or when to administer the fluid and when to stop the administration. So when will you give fluid? So it is very important to know that we have to give just the right amount of fluid, because if you have a restrictive approach, you have hypovolemia, dehydration, low cardiac output, and the ensuing pre-renal dysfunction. If you're overzealous, you will have tissue edema, pulmonary edema, and poor wound healing. So this you can decide based on static or the dynamic indices of fluid responsiveness. The static indices have very poor predictive value, like the CVP value and the pulmonary artery occlusion pressure. They are having a very poor predictive value, as just like tossing a coin where you have 50% probability of heads or tails. So you should rely upon the more reliable pulse pressure variation of the stroke volume variation, which rely on the cyclical impediment to venous return that is caused by the inspiratory pressure of mechanical ventilation, and which is reflected on the arterial pressure tracing. But however, this dynamic indices of pulse pressure variation, the stroke volume variation, are not reliable if the patient has arrhythmias, if he is spontaneously breathing, or has ARDS. In such scenario, we have to employ the passive leg raising test, where the patient is moved from a semi-recumbent position to a passive leg raising position for a minute, and then the change in cardiac output is recorded. So, or else you can use the end expiratory occlusion test, where the end expiratory hold is given for 15 seconds and the increase in the cardiac output is monitored. So what we have to remember here is you should have a reliable monitor to detect the change in cardiac output with these maneuvers. The next step that we have to know is when to stop administering fluid. Naturally, when you have negative indices of tests of fluid responsiveness, you can stop fluid, or else you should be able to see what is the situation of the lung water, which you can detect by looking at the extravascular lung water index using either the PICO or the EV1000. Or else you can use the lung ultrasound. You can scan the lung and see whether there are more than 8 P lines, whether your lung ultrasound score is more than 8. The third scenario is when you have decreased contractility, which can be measured by using the echocardiogram, either the transthoracic or the transesophageal. With the advent of the hemodynamic TE management, where you can put in the TE probe for almost continuously or for up to 72 hours, you have 3 different views which you can have a direct visualization, as well as you can look at fluid responsiveness by the superior vena cava collapsibility index. Now you can integrate all these and decide on the treatment. Suppose your patient is preload dependent, you can give volume infusion, and you then look at the contractility. If that is decreased, you can then proceed by giving an inotrope like dobutamine. And then how do you see whether your treatment is effective? You should look at whether the cardiac output is increased, or whether the markers of tissue hypoxia or tissue well-being, whether they have decreased. That is, whether your lactates have come down, whether your base deficit has come down, and whether the saturation of your central venous oxygen has gone up. So the various endpoints that are used in the goal-directed therapy are the traditional mean arterial pressure, the central venous pressure, the urine output, the cardiac index, the stroke volume index, and the systemic vascular resistance. And recently we have the flow-based values of the stroke volume variation and the pulse pressure variation, and also the values of tissue well-being, that is your saturation of your central venous oxygen and the mixed venous oxygen saturation. Now coming to the literature review on cardiac surgery population, way back in 2000, there was a study published by Polonen and colleagues from Finland in anesthesia and analgesia, where they found that implementation of an goal-directed hemodynamic therapy definitely reduced the length of hospital stay and also reduced morbidity, as evident from the number of patients having organ dysfunction at hospital discharge, which was less in patients who underwent early goal-directed therapy. A meta-analysis by Aya and colleagues published in the British Journal of Anesthesia in 2013 showed that early goal-directed therapy did not change the mortality, was not effective in reducing mortality. However, when the postoperative complications and length of stay were seen, the forest plot showed that there was definite benefit from early goal-directed therapy. We had a study from the Delhi Cardiac Anesthesia Society published in 2015, where they implemented goal-directed therapy in patients who underwent CABG on pump. And they showed that perioperative goal-directed therapy can shorten the duration of ventilator dependency, ICU, and hospital stay in high-risk cardiac surgery patients. Also, they had shown that there was significantly lower levels of biomarkers in the goal-directed therapy group, which supported the importance of optimizing hemodynamic parameters for maintenance of tissue perfusion. Another study from the All India Institute of Medical Sciences by Poonam Malhotra and colleagues in 2017 showed that goal-directed therapy associated with a decrease in the total duration of hospital and ICU stay and decreased duration of inotropic support in patients undergoing op-cap surgery. Another study from the UN Mehta Institute of Cardiac Sciences at Ahmedabad, where they studied the effect of goal-directed hemodynamic therapy in post-cardiac surgery patients. And they concluded that early goal-directed therapy reduces postoperative ventilatory period, reduces the frequency of changes in inotropes, and reduces the incidence of acute kidney injury. And another trial, which was published in the Journal of Clinical Medicine very recently last month, which was published last month, showed that individualized goal-directed therapy for cardiac surgery patients can reduce ICU length of stay and decrease the amount of inotropic support. So what does the various societies say? The Society for Anesthesia in France came out with their guidelines for perioperative hemodynamic optimization in 2013. They said that in patients who are at high risk, definitely we should measure stroke volume in order to reduce the postoperative morbidity, hospital stay, and recovery time. The European Society of Anesthesiology also advocates implementing perioperative goal-directed therapy, and they say that it decreases postoperative complications and hospital length of stay when compared to standard management. What about the American Society of Anesthesiology? They have included the goal-directed therapy in the intraoperative phase of the perioperative surgical home coordination of care. And what about the ERAS Society recommendation? The ERAS Society has recommended goal-directed therapy as a level 1 recommendation with a grade of evidence as B. So which device will you use for which patient? And if you look at it, the traditional pressure-based parameters are of not much use in goal-directed therapy. It is the flow-based parameters and the markers of tissue well-being which are shown to be of much use when you use goal-directed therapy. So for perioperative monitoring of patients who are at high risk, if you anticipate there will be no change in vascular resistance, you can use a minimally invasive cardiac output monitor. Whereas if you expect major changes in the vascular resistance, it is always better to use the PA catheter, the PICO, or the EV1000. In the ICU, definitely you will have patients who are sick, who would be requiring vasopressor support. So it will be always better to use a PA catheter based or a PICO or a EV1000 monitor. In spite of all these benefits, why there are limitations and adoption roadblocks? Well, that is because there is lack of high-level evidence, and there is a lack of a clear-cut approach that has been mentioned. And also we have certain uncertain cost benefit because of the initial expenditure that is required for the purchase of these monitors. So goal-directed therapy, you should hit early and personalize. So these are the four very important things you should hit early. That means you should preemptively give goal-directed therapy. You should personalize according to the patient's need, and you should use the right tool and use the right endpoint. So summarizing, it is necessary to put the hemodynamic variables and measures of VO2 and DO2 into context, and you should integrate all these values and solve the hemodynamic puzzle. Remember the 5 T's, that is the target population, high-risk patients, timing of intervention, start early, type of intervention, you should combine fluids, vasopressors, and inotropes. Target variable, you should target the blood flow variables and the measures of tissue well-being, and you should have a target value which should be personalized. So always initiate resuscitation with perioperative goal-directed therapy, and then measure the effectiveness of the resuscitation by looking at the microcirculatory endpoints. Thank you very much.
Ever since its introduction as a bedside right heart catheter by Swan and Gans in 1970, the PA catheter has had a 4-decade-long journey full of controversies, which brings us to the present-day question and my topic for today, whether the PA catheter is a fading tool amidst an advanced armamentarium. The first data on the PA catheters were published in 1987 by Gore et al. And showed a sharp rise in PA catheter use together with an increased mortality after myocardial infarction. The support trial showed increased 30-day mortality in critically ill patients and increased utilization of resources. Complications have led some authors to call for a complete moratorium on the use of PA catheter. The Pac-Man trial failed to show any benefit or harm with the PA catheter use. Patients undergoing off-pump CABG have showed no difference in mortality and the final outcome. The ESCAPE trial demonstrated functional improvement with the PA catheter-guided therapy used in patients with congestive heart failure. Despite these arguments, the PAC is still considered the gold standard for monitoring of cardiac output. Due to the inherent risks, investigators have tried to develop minimally invasive or non-invasive monitor for monitoring of cardiac output. So what are the underlying factors leading to the PA catheter nearly losing its relevance? Mortality and morbidity risk, lots of complications associated with use, misinterpretation of data by the undertrained, various technical errors which can lead to false readings, intracardiac shunts, mechanical ventilation, valvular dysfunction can lead to incorrect readings. Newer, less invasive monitoring devices, therefore, are finding more and more space in routine hemodynamic monitoring during cardiac surgery, which can be reflected by the negative annual growth of 2% in sales of PA catheter, while there is a 15% positive growth for newer monitoring devices. The following hemodynamic data can be obtained with the use of PA catheter, like the central venous pressure, pulmonary artery pressure, PCWP, cardiac output, and derived data like the cardiac index, stroke volume index, systemic vascular resistance, pulmonary vascular resistance, together with oxygen transport parameters like delivery of oxygen, oxygen consumption, and mixed venous oxygen saturation. In the following slides, we will compare the newer modalities of cardiac output monitoring with the standard thermodilution PA catheter. Transesophageal echocardiography measures the cardiac output, right ventricular systolic and diastolic pressures, LV filling pressures, together with cardiac structures, visualization of cardiac structures, filling status, and cardiac contractility. It is a useful tool in hemodynamically unstable patients under mechanical ventilation. However, its disadvantage is that it requires a skilled operator and TEE probe cannot be kept for too long. The LIDCO. It combines pulse contour analysis with lithium indicated dilution for continuous monitoring of stroke volume and stroke volume variation. Its disadvantage, it requires frequent calibration, and its accuracy can be affected by aortic regurgitation, IBP, damped arterial line, intracardiac, extracardiac shunts. It has been validated with good correlation with PA catheter. The PICO, cardiac output measured by the Stewart-Hamilton principle from the thermodilution curve, is used to calibrate a pulse contour algorithm. Volumetric preload parameters can be measured like the intrathoracic blood volume, global end diastolic volume, extravascular lung water, as well as markers of fluid responsiveness like the stroke volume variation. It requires frequent calibration, especially during hemodynamic instability, and its accuracy can be affected by vascular compliance, aortic impedance, presence of air bubbles, clots, and in conditions like valvular regurgitation, significant arrhythmia, and rapidly changing temperature. It has been found to have a good correlation with PA catheter during CABG, but not during off-pump CABG. The EV1000 or the volume view, it is analogous to PICO, and it has been validated against PICO and thermodilution, transpulmonary thermodilution in critically ill patients. The flow track, it is based on the principle of linear relationship between pulse pressure and stroke volume. The system does not need any external calibration, is operated independent, and is easy to use. However, its accuracy is affected by significant arrhythmias, IBP, and morbid obesity. It has been found to have good correlation with the PA catheter in off-pump CVG patients as well. Esophageal Doppler, it is placed in the esophagus at the mid-thoracic level, and cardiac output is measured by multiplying cross-sectional area of the descending thoracic aorta and the velocity time integral of its flow. It has its disadvantage. It measures flow in the descending thoracic aorta, which is only 70% of the total flow, and discrepancies in flow in aortic coarctation, aneurysm, cross-clamp, IBP, and various factors which affect the cross-sectional area like changes in pulse pressure, vascular compliance, use of inotropes, circulatory failure, can lead to miscalculation of the cardiac output. It has been various studies find good agreement with the PA catheter. NICO system or the partial carbon dioxide rebreathing, major limitation, it requires tracheal intubation with fixed ventilator settings. It is not very accurate in severe chest trauma, significant intrapulmonary shunt, and in validation studies have not found accuracy with the PA catheter. Ultrasonic cardiac output monitor, major limitation, alignment of the USD beam with the blood flow is dependent on proper probe positioning, and the cross-sectional area can be affected in various physiologic states. It has been found good agreement with the PA catheter in post-cardiac surgery. Thoracic bioimpedance, major limitation, interference with electrocautery, proper electrode placement, patient's movements, arrhythmias, presence of sternal wire. In validation studies, studies in cardiac surgery reveal good correlation with the PA catheter intraoperatively, but not postoperatively. Bioreactance, superior to bioimpedance, limitations, dependent on body size, aeration of lungs, affected by extravascular lung water, alveolar collapse, consolidation. Validation studies showed good correlation with PA catheter. Over the years, some survey studies have been conducted to assess whether anesthesiologists prefer PA catheter as a monitor during cardiac surgery. A 1998 cross-sectional survey amongst anesthesiologists in Canada and US, with number of respondents 265, they found that the PA catheter remained the preferred monitor in both cardiac and vascular surgery. A questionnaire survey of 100 practicing cardiac anesthesiologists in India, published in 2002, found that the routine use of TEE for adult cardiac surgery was very low, 8%, and that of the PA catheter varied from none to all. The general consensus was that the PA catheter and TEE are complementary and not competitive. Another questionnaire survey amongst members of Society of Cardiovascular Anesthesiologists with 854 respondents, published in 2015, concluded that the majority of responders still prefer to use PA catheter for most cardiac surgeries. TEE remains the most popular supplemental and alternative hemodynamic monitoring tool. Therefore, from the survey studies, we see that the strongest contender for the PA catheter is the TEE. However, they are complementary rather than competitive. The reasons being, all data pertaining to pressures, resistances, and flows are more reliably determined by the PA catheter. The TEE surrogate of PCWP, which is a time interval between the onset of early diastolic mitral inflow velocity and annular early diastolic velocity, requires expertise and is difficult to apply in the intraoperative setting. The general consensus regarding measurement of cardiac output by TEE is that it is strongly operator dependent and less reliable than the thermodilution technique. TEE provides a good profile systolic function indices like LV size, ejection fraction, fractional area change, which are not possible to measure by the PA catheter. Diastolic dysfunction can be diagnosed and graded only by the TEE. Fluid responsiveness is better defined by TEE-derived variables like left ventricle end diastolic area, but some information can be derived from PA catheter as well, like the PCWP. Unlike TEE, PA catheter allows measurement of mixed venous oxygen saturation and oxygen delivery and consumption variables. Limitations with TEE are that it is a semi-quantitative method and does not permit continuous monitoring. A cross-sectional male questionnaire survey of anesthesiologists in Canada and US, published in 2002, to assess the current clinical practice attitudes amongst anesthesiologists in cardiac and vascular surgery with regards to the most appropriate indications for the use of PA catheter, assessed in 36 clinical scenarios, found that 87% of the anesthesiologists strongly agreed that the use of PA catheter is appropriate in severe ventricular dysfunction and unstable angina. A majority, about 53%, rated the PA catheter is not appropriate in the routine patient without complicating risk factors. Studies show no benefit of PA catheter over CVP catheter in low-risk patients with preserved ventricular function undergoing off-pump CABG. Therefore, why does the PA catheter still remain useful in clinical practice? The reason probably is that the PA catheter is the only tool that provides continuous monitoring of pulmonary artery pressure, right-sided and left-sided filling pressure, cardiac output, and mixed venous oxygen saturation. Risks are mainly due to insertion of a central catheter, not a PA catheter, and additional costs are minimal relative to the cost of intensive care. Therefore, we can safely conclude that the PA catheter is here to stay, although its use cannot be recommended as a matter of routine. It has a definite role in select group of patients undergoing cardiac surgery, those with present and possible hemodynamic instability, as in conditions like LV systolic and/or diastolic dysfunction, low output state, need for LV reshaping, RV dysfunction, pulmonary hypertension, need for mechanical circulatory support, and mechanical complications of AMI. In order to translate PA catheter-derived data into tangible outcome benefits, the PA catheter has to be used within the context of a defined treatment protocol. These are my references. Thank you.
Good morning. I'm Avi from Amrita Institute of Medical Sciences in Kochi. Thank the organizers for inviting me. Today I'm going to talk to you about venous function, an aspect of physiology which concerns us in everything that we do, but which we rarely think about. This is a little about me. And mainly, I'm interested nowadays in cardiac intensive care. I have no disclosures to make. In the first section, I'm going to describe venous physiology. And in the next section, I'm going to use this description to analyze some common situations. So what is it that determines the cardiac output? That's the question that mainly concerns us. Now, so far, most of our focus has been on the heart, but we need to remember that the heart can only pump as much blood as it gets. So venous return, if it's low, can impede cardiac output. The most common example, of course, is hypovolemia, because major veins tend to collapse when you have low volume status, as you can see in the picture alongside showing a collapsed IVC. So even the heart may empty to whatever extent it can only pump what it gets. Now, just like we use for understanding concepts such as cardiac output and SVR, a similar conceptual framework can be applied to veins, which says that the venous return is dependent on a filling pressure in the veins minus the RA pressure, because it's the RA pressure against which this venous return has to work, divided by the resistance across the venous circulation. Using this framework, we get a series of venous function curves. The most important thing I want you to realize in this is that as your RA pressure rises, your venous return falls. You can see that with progressive increase in RA pressure, your venous return falls. So to get the same venous return for an elevated RA pressure, the systemic filling pressure has to increase. This is familiar territory. It just shows you Starling's law of the heart. So essentially, what Guyton proposed, and which is now fairly well proven, is that cardiac output is determined by intersection of the venous return curve, the venous function as we speak of it, and the cardiac function. So as both of these interact to fix the cardiac output. Now, take an example. When your heart starts to fail, your cardiac output tends to decrease because not only is there forward flow does your forward flow fall, your RA pressure increases. As your RA pressure increases, for the same amount of filling pressure, it decreases your venous return. People use a bathtub analogy, which says the primary function of the heart in terms of the venous system is to drive down the RA pressure. When it drives down the RA pressure, it creates a vacuum or suction force for veins to return blood to the heart. But there are limits to which this can be done, because as I pointed out initially, if you start to bleed or become hypervolemic, however much your heart pumps, your veins will collapse and your venous return will drop to near zero. When this happens, your cardiac output will automatically start falling. And in such cases, your cardiac output is not dependent on the heart, but on the venous return. Likewise, when you have impaired cardiac function, on the other hand, you will find that your RA pressure is high. However much your venous pressures are, they have to overcome this RA pressure to fill the heart. Therefore, your cardiac output in this situation is predominantly now determined by the cardiac condition. It's cardiac limited, not venous limited. There is another part that you have to realize. Most of our circulating volume is actually stuck in our tummies, namely the splanchnic vasculature. So as a result, you have a very small amount of your blood actually in circulation. 30 to 40% is waiting in the splanchnic circulation. So we talk of the blood in the splanchnic circulation as the unstressed volume and actual circulating blood as the stressed volume. Venous resistance, although we do describe it formally, is not a very important factor, because most theoretical frameworks seem to suggest that it's the filling pressures that determine venous function and not the venous resistance. So now I'm going to give you a few examples to understand this better. Now, you go to a casualty, you examine a patient who's actively bleeding. You often find some of these patients actually normotensive. Okay, this is a classical example. Why is this patient normotensive? Well, the answer lies in that as he starts bleeding, your unstressed volume starts to empty into the stressed volume. Now, as the unstressed volume starts to get exhausted, that's when he starts to hypotense. Till then, this patient will be normotensive. Okay? Next, we turn our attention to the CVP. What is its exact role in our clinical practice? If you ask the trainee, he says it reflects volume status. I'll show you why this is not exactly true. This is a paper, systematic review, which shows that CVP actually doesn't predict volume responsiveness. You can see that the CVP has absolutely no correlation to the volume status. Formally, it's described that the area under the curve of CVP to predict volume responsiveness is only 0.56, which is as good as tossing a coin. The same group of authors replicated this evidence 10 years later and found still was valid for both the OR and the ICU. Using the CVP to predict volume status for your patient is as good as tossing a coin. Therefore, the CVP does not measure volume. What the CVP does measure is the complex relationship between your heart and your venous function. So this composite intersection that the CVP measures. To give you a classical example, I've already said, a high CVP impedes venous return. So even though you're flush with fluid, there's actually no circulating volume for your heart to pump, and therefore your venous return drops. I'll tell you why this is exactly not always true, because it determines in which part of the Starling curve your heart operates. This is something for you to keep in mind. The PCWP doesn't particularly do better, because the PCWP is also has additional now complicated elements such as interposed, such as the right heart and the pulmonary circulation. The composite capacitances or resistances of these additional elements need to be factored. Again, high PCWP tells you something more about your chamber function, but less about your proximal filling status. That's something that you should always keep in mind. The additional things that you have to keep in mind are aspects such as diastolic function, because they impact the PP relationship. And the effect of transmural pressure, such as when your patient is on a ventilator, because the external pressure can impact the static measurements. Okay, so then should we discard measuring the CVP and the PCWP? Not exactly. What the CVP and the PCWP are actually exemplifying is that they're telling you you're in trouble. When you have a high CVP, it's almost always abnormal. It doesn't as much tell you about the volume, but tells you that the heart is not actually allowing the venous return to empty or the right heart to empty into the left atrium. And these have effects such as kidney afterload, pulmonary hypertension, and so on. Okay. So PCWP and CVP should primarily be seen as indices of chamber function. Once you're sure that they're remaining the same, only then can you apply them to assess volume. For those of us who have fair amount of practice doing open thoracic surgery, we find that when we clamp the supraciliac aorta, the filling pressures in the proximal upper half of the body dramatically increase. Why should this happen? Simon Gellman from Harvard has explained this beautifully. He spent his lifetime describing some of this. What he said is that when you apply aortic cross clamp, the entire splanchnic volume, the so-called unstressed volume, empties into the upper half of the body, increasing your filling pressure. Whether or not it increases venous return depends on how well your heart handles the afterload. If your heart starts failing, your CVP or PCWP will rise and venous return may get impeded. In such a situation, you will have low cardiac output and congestive symptoms. When you acutely resuscitate patients, this is something you need to remember. This is about venous resistance, because you rapidly hemodilute a patient when they are losing blood, you tend to dramatically drop the resistance to flow, and that increases your stressed volume. However, as you continue to be shocked from bleeding, catecholamines increase and they act on the veins to increase the venous resistance. This explains why you may have a dramatic response to initially administered Valium, but this effects gradually peters off. Phenylephrine, a drug which people use a lot nowadays, can actually increase the cardiac output. How does it do so? It does so exactly like an aortic cross clamp. It retards blood flow into the splanchnic circulation, causes it to decompress, causes your unstressed volume to enter the stressed volume, and therefore could increase venous return. Again, whether or not it actually increases venous return it depends on how well your heart handles it. If your heart is able to manage the afterload better, your venous return increases. However, if the heart can't, afterload causes deterioration in ventricular function, increase in RA pressure, and venous return and cardiac output fall. So essentially, phenylephrine acts depending not so much on the fluid status, but on the condition of your heart. What happens in different types of shock? When you have cardiac shock, when you have cardiogenic shock, what happens is your RA pressure is high, and that impedes your venous return. The only way the veins can empty into the heart is to increase the filling pressure. When they increase their filling pressure, this has side effects such as in the kidney, you get a palpable liver, you get pedal edema. The other important thing that I referred to earlier is remember that in cardiogenic shock, you're actually operating on the flat portion of the Starling curve. The reason why fluid therapy is not a primary therapy to use in patients with overt cardiac failure. You're not going to get dramatic increase in cardiac output just by failing the patient. In sepsis, you have a biphasic response. So actually in sepsis, because of vasodilators, a lot of volume, the stressed volume starts to migrate into the unstressed volume. So your actual circulating volume is low. Now your EDGT and other therapies encourage you to give large volume resuscitation. When you do this, you dramatically increase the stressed volume, and that's when your venous return starts to increase. Your stressed volume causes the venous return to increase because your heart function is at least initially normal. And then you get the hypertonic septic circulation that you normally see. In obstructive shock, you have very high resistance to venous return, and therefore However high the filling pressure is, rarely manages to cause enough venous return to the heart. And you need to give dramatic amounts of fluid, or more usefully, relieve the cause of obstruction. Now, what is this big confusion about how much fluid to give? The answer lies in the venous function two-compartment model. While we give fluid, we are not able to arbitrate whether it goes into the stressed or the unstressed compartment. Finally, when you see patients with widely fluctuating arterial pressure, the most extreme is pulsus alternans. In cardiac patients, this does not reflect fluid status. It just reflects increased interventricular dependence and possibly right-sided failure. Do not use dynamic indices of fluid responsiveness in patients with overt heart failure. That's all. Thank you for patient listening.
Very much. All the three speakers, I think, have stuck to the discipline of the 2020 over and very well presented, all of you. So I would request Professor Khalilur Rahman to say in a few minutes quickly, concisely, the gist of all the three presentations. Then we'll go to the Q&A.
Good morning from Dhaka. Greetings from Dhaka as well. And this virtual platform make it possible to see all of you from different parts of India and different parts of the world. And my greetings to all of you. This session, the 8th session, we enjoyed 3 very important lectures, and we enjoyed, and they presented very nicely. And the first one, the goal-directed hemodynamic therapy by Dr. Venous Venugopal. This is very important because the adequate organ perfusion is dependent on the optimum hemodynamic parameters, and he nicely elaborated all this thing, how important it is to use when we use vasoconstrictor or volume or inotrope, which is the right choice. It should be done in a clinical situation when we need some parameters to guide us to do that. And he nicely pointed out regarding the target population, timing of the initiation of this treatment, and type of intervention, and varieties of intervention for probabilities. Now, thank you, Dr. Venugopal, for a nice presentation. Second lecture was the PA catheter related issues, and Dr. Soumita nicely presented and compare advantage, disadvantage of the new methods that helps us to determine the different parameters in cardiac output, T, flow track, LITCO, PICO, isodoppler, and other new techniques that helps us in the patient management. Whatever it is still the PA catheter has its role in different situations when we use them in a different cardiac surgery, especially the right heart or any pulmonary vascular resistance or anything we do handle. And that has a great role in early detection of some procedure still. And though the PA and the TE has limited use in our societies in India and Bangladesh as well because of the constraint of the situation and cost and everything. But still it has its role, and she nicely pointed out all these things. Third, but not the least, a very important topic that sometimes we forget, the venous role of the hemodynamics. And Dr. Avik Jayant nicely pointed out, and this is one of my favorite subjects actually, when we are in a dilemma of bad patients, what is the ideal way to deal with? We can immediately take volume of the venous system, we can take back volume to the veins using phenylephrine, vasoconstrictor, and we different time we use cross clamp and other thing. We use the position different time in beating heart surgery, etc., etc. So vein has its important role in our hemodynamic and management protocol. So he nicely discussed about stressed and unstressed status of the venous system. And especially it is how the role of the CBP, role of these system in the sepsis and other situation. So I think his presentation, everybody enjoyed, and we'll discuss. And next to Professor Dr. Yatin Mahota to conduct the question answer session. Thank you very much.
Thank you, Professor Rahman, for your comments. So I think I'll open up with a few questions which have come in the chat box. One is from Dr. Vaikar, and this is to Dr. Manju Bhutani. Then other panelists can quickly add if they want to, or we'll move on to the next one. Manju, Vaikar says that the role of CVP is limited, whatever most of the studies, but all of us use CVP catheter for in cardiac surgery for administration of inotropes and vasodilators, I think. So, do you still attach it to a transducer?
In our hospital, we still do attach it to a transducer because you have the option to add on any other monitoring if you need at the moment. So with our, I mean, we do use the Edwards system for the goal-directed therapy and all the other monitors. So, but we still do attach it.
Yeah,
So
I think most of
I think the Venous talk was very good. It gives you some indication. If you're not putting a PA catheter and you're not attaching a cardiac output monitor.
See, that is correct. See, venous pressure, basically, there are two extremes where venous pressure would be very useful. If the CVP is very low, maybe you should give fluid. And if the CVP is very high, don't give fluid. These are two things very, very clear. In between is a confusion.
It's some trending. It also gives you some trending.
Trending.
Not enough.
Yeah.
Not enough. I agree. But if you're not using a cardiac output monitor separately, then or a PA catheter, then it gives you some indication.
Yeah. Rajesh, one question from Sandeep Mutha. Complications of PA catheters. So I have a large experience of PA catheter use of complications. What is the personal experience?
So coming from you that I have a large experience, you are my godfather and my middle name is cardiac PA catheter. So, and you would bear me that notwithstanding literature, we in our experience in Escorts and Medanta, our common experience, if we combine, I don't really recall complications which will deter us from our regular or near routine use of Swan Ganj or PA catheter. That's what I have to say. And continuing from there, my max experience also, and if I share experience of my co-workers, I would say PA catheter in right hands is a very, very safe, and whatever the complications are, they are about central venous puncture, and rest I don't really believe that it is, or I have not seen it, sir.
In that article by Michael Pinsky and John Louis Mansa, again it says the same thing. The complications are primarily because of the central line insertion rather than the presence of the PA catheter. Unless you leave it obviously in for too long, you'll get bacteremia and thrombocytopenia and all those things. Otherwise, I find it, in experienced hands, I don't think there's safety is an issue. Misinterpretation can be an issue, actually.
Yes.
In a few studies, they have shown that. Professor Rahman,
Yes.
what is your experience in volume responsiveness assessment by
I
PLR?
can listen you.
What is your assessment
You
for volume responsiveness in cardiac surgery? Oh, you can't hear me?
I am failed to listen you.
Oh, I'm so sorry. Others are able to do so.
So maybe his net is not
Good enough? Okay, so that was a question from Muthu Kumar. The role of PLR, passive leg raising, in cardiac surgery. Dr. Khalilur Rahman, you can join in whenever your audio improves.
So shall I answer this?
Yes, oh sure, yeah.
Sir, passive leg raising we don't do, but from our off pump experience, we have seen that how many times we either lower the head end or raise the head end to reduce the filling or to increase the filling. So at least indirectly we can validate that we have in our ICU also, we use the ICU when the pressures are low. So we use it very routinely without thinking.
I think we should use it more often than what we do.
Yes.
Because that's the most benign way with the monitoring which we do to assess the volume responsiveness of the patient.
And
you're not harming the patient. If you're lifting the legs transiently, you're not harming the patient in any way.
So most benign and quickest perhaps, but it is the most quick.
But
also you're not volume loading. Also you're not volume loading suddenly. So this is your innate volume which you can reverse to.
That's what I meant. But many years back, I and Deepak Tempe jointly published a study which was multi-center between Escorts and GB Pant. In patients with poor LV function, PLR was not that good. I mean, as a good indicator of volume responsiveness as compared to the normal LV functions. So that is another thing which we need to look at. Then there is a question. I think any of the the speakers can go in. The venous circulation was a very good talk because it's a completely untouched subject. So I'm glad it was put into the thing. There is a lot of awareness about that, and that also affects the right and left heart interaction. So I think there is something called a closing pressure. So would you like to comment on that? Because see, if the gradient of the venous pressure and the RA will determine the venous return. But if the venous pressure is RA is negative or almost near zero, then the intrathoracic vessels veins collapse and the venous return will become zero. So that's also important. Would you like to add something, Dr. Jayant?
Yeah, the confounder is probably mechanical ventilation, because when you're in crisis and you're in a control mode of ventilation, mechanical ventilation adds to this double jeopardy. If so, this actually there is a therapy here where you would lighten, and it's, you know, particularly in the ICUs where you would light. If you have precarious volume status, it often helps to go on to pressure support ventilation and reduce mean airway pressure, because that will recruit volume. So this is the exact impact of dynamic indices in impacting volume status assessment in cardiac surgery. However, to use this on a beat-to-beat basis, I have already said that this is not a good idea because, you know, one, you lose pericardial restraint the moment you open the heart. So that alters your interventricular interaction. Second thing, many of your patients probably paced, in which case septal function is not normal. And finally, of course, if you have occult RV dysfunction, that's the most common cause of, because your RV is not delivering volume to the LV and just acting like a passive conduit. So when you actually, during the inspiratory phase of mechanical ventilation, that's when some volume leaks into the LV. So you just get widely fluctuating pulses with mechanical ventilation. I think that's my take on this.
Also, there is a lot of interaction with PEEP.
Yeah,
so whether the patient has a good LV function or poor LV function. Because if the patient is on poor LV, then PEEP will have different effect. It is not going to be as bad as what it is to be in a hypovolemic patient. Also, it depends whether the patient is normovolemic or hypovolemic, because that will also affect the venous return, depending on what are the effects of PEEP on that. So these curves are different, you know.
Correct. And in patients with poor ventricular function of any etiology, whether it's right or left, fluid is not the primary therapy. Right? So there is not much to decide based on fluid therapy. We're going to look at other ways of decongesting patients.
Well, the person who gave a talk on EGDT may differ with you on that, because one of the things which they do is give fluids. So I think first thing which they do.
But you know that we have now come to a point where we're questioning the reverse, EDGT in sepsis, where people were asked to give fluid, and they still the surviving sepsis guidelines say give fluid. But this is.
See, on the lighter note, I think we are reaching the end of a session now. But on the lighter note, many years back, I was visiting Brown University, where the #2 author of Reverse's paper was trying to show us how central venous oxygen tension pressure is going to affect SO2 is going to change the management. And he was introducing a central line, and he had major difficulties. He spoiled the catheter. He caused a pneumothorax. In front of us, he had to put in a chest tube. So that is how the science goes. I mean, he was #2 author. So science and practical aspects can also be quite variable. So I think we just have a minute left. So I just have one thing to add about the venous district. There is a new drug which is now just introduced in India, which is called Xanthequin. Xanthequin is it affects on alpha-2 beta receptors, so it produces venous constriction, and it produces certain degree, small amount of arterial dilatation. So on one hand, it will produce venoconstriction from the splanchnic to increase the venous return, and on the other hand, it improves the flow because afterload is slightly reduced. So the left heart pumps a bit better. So it has been used as therapy. It's already DCGI approved now, and it is used for therapy for hypovolemic shock. It works quite well for 6 to 8 hours to buy you time to be able to resuscitate the patient. So that fully fits in with what you are saying. There is plankton circulation. If there is vasoconstriction, the venous return will increase. But again, as you nicely explained, that there is a stressed volume and there is unstressed volume. But that level of stress and unstress you can change by using these vasoactive medications which are now available. So it is very important to understand. As cardiac anesthesiologists, we understand the cardiac output and SVR and PVR quite well and ejection fractions. But the venous role of venous system, we do not appreciate it as well as what we should do with the other things. Regarding, I think till I can see a couple of more questions in the, yeah. Vaikar, then when we have reservations, the time is up.
Yeah,
okay, thank you very much.
Thank
you. Thank you so
very much.
Thank you.
Thank you all the speakers, all the chairpersons, and especially Dr. Yatin Mehta. He's been he's the founder of IACTA with a group of people in Ooty, I remember, and nicely conducted sessions. I want to make few announcements from IACTA side. All of the IACTA members, all the IACTA life members have been sent an email to join the link at 1:30. Those who have not filled the form, the brochure, the link to join GBM is given. Click to that link and you will be seeing a form on the screen. Enter your details and IACTA number and mobile number, email, and we'll send you the email on your registered email also, and the email which you have entered in the form. At 1:30, you click to the link. You will get a reply email from us. In the reply email, you will find a link of a Zoom meeting. That is IACTA Zoom, GBM Zoom meeting. Click to that Zoom meeting link and you will enter the Zoom meeting. And the link will be open at 1:30 today and the meeting will start at 2 o'clock. The same thing we are sending to all IACTA members by SMS also. Whatever the registered mobile number for yours is with us or you have filled in the bit.ly form, we are sending SMS on that. And in the SMS, there is a link. If you click to that link, you will directly join the GBM Zoom link, Zoom meeting at 1:30 and the meeting will start at 2:30. And the second announcement, many delegates are asking how to get the delegate form with the CME credit points. The Delhi Medical Council has given 4 credit points to our meeting. And after this conference, we'll be sending an email to all the delegates who have joined this meeting. We have their emails, and on that email, we'll be sending a form. You fill the form with your details, then the name you want to be printed on the certificate, along with your state medical council number. Once you send that form with your name and the state medical council number, we'll generate the certificate and send you as a reply email on your email. So this is standard practice. And now I thank all of our chairperson and the speakers. And back to the media team to start a new video of one of the sponsors.
Thank you.
Thank you all. Thank you all.
Thank you. Thank you very much.
Thank you very much.
Great job.